Hi, Girl Scouts. It's so good to see you. I do recognize some of you in the participant list that I have. So it's so good to see you guys back here again. If you haven't met me already, my name's Katie Herstein, and I am the Program and Events Manager at Girl Scouts of Colorado. And so I get to be the one in my job that gets to host this virtual series, Inspiring Futures, and where we get to introduce you to accomplished women in a whole variety of professions so you can start to be inspired about what your future might look like. So it's been pretty interesting journey for me too, that I get to sit back and watch all of these inspiring women talk about their careers and think, maybe I should have done something like that. It's been a lot of fun. So we have the perfect partner working with us to bring this series to you, and that's College Invest. So College Invest, they're Colorado's college savings program, and it makes it easy to save for your education after high school. So as a Girl Scout, through elementary school, middle school, and high school, you're working on leadership skills and life skills and everything. And then you head off into the big world to go off to college, and College Invest can help you and your families pay for that. So they basically exist so that they can help fund your future in your educational pathway. So I started a College Invest savings plan for both of my Girl Scouts when we moved here about 10 years ago. And I have a daughter who just today decided to go to University of Colorado in Denver studying psychiatry. So she's super excited. And we're pretty happy that we put away money into the Colorado savings plan to help pay for that, for her education. So it's like a piggy bank where you put money in, and the benefit of this piggy bank though is the money grows tax-free. So when you take it out, you're not paying for your taxes on it. So it goes even further. And the money that you put into a College Invest savings plan can be used across the country for trade school, apprenticeships, colleges anywhere across the country. So it's a wonderful thing. So I'm going to show you a quick video from the CEO of College Invest about what she hopes that you'll get out of today's session.
Hi, I'm Angela Beyer, CEO of College Invest, and welcome to this episode of Inspiring Futures. Through Girl Scouts, you've learned that if you can dream it, you can do it. And here at College Invest, Colorado's education savings program, we help you get there. And you're never too young to begin to imagine your inspired future. So how will you impact this world? Will you run your own business, invent a new technology, or maybe even discover a life-saving cure? But wherever your inspiration takes you, a College Invest savings plan can help make your dreams a reality. Now, prepare to be inspired.
Great. I know she inspires me when I listen to that. So just a few housekeeping items. So we are recording this, and we do put our recorded videos up onto our Inspiring Futures YouTube channel, but I edit them and I make sure that I crop out any of girls' faces just so you don't have to feel that it's sort of out there in the YouTube world. So we would love right now if you want to show your faces, interact with us in the chat room, whatever you feel most comfortable with. We would love to be able to interact with you. So, and next up, before we do all of our meetings, we do our Girl Scout Promise and Law. So if anybody feels comfortable, you can unmute yourself and join along with me on whatever you'd like to do. So you ready? On my honor, I will try to serve God and my country, and help people at all times, and to live
by the Girl Scout law.
And the law is, I will do my best
to
be honest and fair,
friendly and helpful,
considerate
and caring,
courageous
and strong, and
responsible
for what I say and do,
and to respect myself and others, respect authority, use resources wisely, make the world a better place, and be a sister to every Girl Scout. Awesome. Thank you. I love when I have people participating with me, and sometimes there's about 10 people and it's all jumbled and I love it. It's fun. So next, we're introducing our guest speaker today, Dr. Katie Bakes. So she is an emergency physician at Denver Health and a professor of emergency medicine and pediatrics at the University of Colorado School of Medicine. So her work as an emergency physician in Colorado's primary safety net institution fosters her efforts in the areas of violence intervention, and Prevention, Children's Needs, Diversity, and Social Justice. And to add to all of that, Dr. Katie Biggs, she was also honored at the Girl Scouts of Colorado's 2021 Women of Distinction event last September. So I was actually there at staff and got to see her, and that was pretty fun to see that too. So I'm going to stop sharing my screen and welcome Dr. Katie Biggs.
Okay, let's see if I can do this right. You all will have to tell me if you see my screen okay. Everybody see it? Give me a thumbs up. Awesome.
We do.
So I am transitioning in my jobs right now. So I was at Denver Health for about 20 years and starting to work over at the VA and doing more pipeline work, which I'll talk to you about in a second. But I want to give you a little glimpse into what being an emergency physician is all about. And again, you know, I've been practicing for about 25 years, so kind of seen everything you could see in all the places I've been and the work I've done. So you all may be wondering, like, what is emergency medicine? I'm sure you've seen some TV shows and maybe heard news stories or seen things on the news, but it really is a very unique profession. So it was first actually created in 1979. And I was born in 1970, so it wasn't even a specialty when I was born. So relative to other things like surgery or internal medicine, it really is a novel specialty that was born out of a vision of a man named Peter Rosen. He was actually a surgeon. And what he recognized was that somebody comes to the emergency department, right? Let's say they have chest pain. Well, it used to be that emergency departments were kind of split up. So on one side would be medical complaints, and on the other side would be surgical complaints. And so you had those specialties staffing those two areas of an emergency department. But what it turns out is that when a patient comes in, for example, with chest pain, it's not clear which side they belong on. For example, they could be having a heart attack, or they could be having a pneumonia, or maybe they have an injury to the big vessel in their chest called the aorta that requires a cardiovascular surgeon. Or maybe they have, pancreatitis that's going to need a gastroenterologist. And so rather than having all these specialties in the emergency department, the specialty of emergency medicine was really created to be able to differentiate what the causes of chest pain are, who needs to fundamentally treat that patient, and what's safe to send home and what's not safe to send home. And that requires a certain skill level that means you have to understand all these different causes of chest pain, but you also have to be alert to some things that could trip you up. So the things that could trip you up, that really is the crux of what we're trained to do, is to look at things like bias, shortcuts, and illusions. And I'm going to show you some examples. This picture, actually, some of you may think it's an illusion, but it's actually a really good example of bias. It's unconscious bias. So I don't know if you guys can tell me in the chat, or if you can show your pretty faces and give me a thumbs up, or who sees it as a blue and black dress versus who sees it as a white and gold dress, right? So who might see it as a black and blue dress, right? All right. So the one face I'm seeing sees it that way. I've got some chats in here. Okay. So what's really interesting about this is that there are people that can actually change their vision to see it either way. And some of you may already say, oh, I can make myself see it white and gold, or I can make myself see it black and blue. I see it black and blue. For whatever reason, I cannot change my brain to see it differently. But it really is about bias, because those of us that see it black and blue assume that the picture was taken in natural light. And so even though our retina may see the same image, our brain is saying it's these two colors, or it's these two colors, based on the assumption of what kind of light the photograph was taken in. right? That's an example of a very clear-cut unconscious bias. We know there are lots of other unconscious bias that I'm sure you all could name that have more to do with maybe how we judge people when we first see them. There's also something that we can tend to do that creates shortcuts. And I'm going to show you a few illusions to, these are all kind of illusions, but they demonstrate different things. Hold on, if I can get this. So this is our, this demonstrates our inclination to create shortcuts, okay? So in the chat, maybe you can say, how many do you see? How many Fs do you see? I'm going to close it. Okay. Did everybody kind of pick up on all that? Maybe you can let me know in the chat. But you can see that each of those examples really was a way that our brain makes shortcuts. So we start to ignore things that our brain assumes are not significant. Or we tend to lean towards what's obvious in the color example. And it's very hard for our brain to take input of two different things and still come up with the right answer. And finally, I don't know if there's a way, I probably want to stop. I don't know if you all see do you see the pictures on the side when I'm showing the screen or not?
No,
okay,
we
good.
just see the 5 shortcuts.
Okay, excellent. That's what I want. Okay. I just wasn't sure if that was messing it up. Okay, let me show you one other. And some of you may have seen this before. It should already be up. Nope. Oh, goodness. Hold on. That was not that. Here we go. It's called the monkey business illusion. And I'm going to play that for you now too, okay? I want you to really concentrate on everything going on and try and pick up on any details that are occurring. In addition to that, I want you to count the number of times you'll see these people are going to be walking around and how many times they pass, the players who are wearing white pass the ball. Everybody count it up. Only the ones who are wearing white. Okay. Who got 16? Did everybody see it, or do I need to play it again?
I saw it and I only counted 13.
Okay. All right, we're going to keep playing. Who saw the gorilla? Good. Who saw the curtain changing color? Or one of the black players leaving? Okay. Okay. So, so that's another example of how our brains can not only easily get distracted, but miss really key things. And in an emergency department, you're always kind of looking for that gorilla in the room, right? You're always looking for what's the most critical, dangerous patient and how to identify them quickly and take care of them quickly. Because whether it's an illness or it's injury, we have to identify things quickly if we want to improve outcomes. So I'm going to give you an example of this was a real day in the emergency department. Okay, it was one that I made this up afterward because I was like, nobody would believe this. But I think it's a very good example of, you know, how do you find sort of that needle in the haystack, that gorilla? And typically when patients are, when I come into my shift, I'll have patients waiting to be seen. Okay, so there's patients waiting to be seen, but we may also get ambulance traffic, or there may be critical patients that just come in who walked in. So we always have to be attentive to, okay, who do I need to see first? Who's at the highest risk of kind of going south? And who can wait, right? So on this day, there was a 3-year-old with ear pain. There was an infant that was being transported to us with a hanger in his mouth. And I'm going to show you an image of this in a second, but this was a patient that we were expecting who had gotten a hanger stuck through his mouth. And then a 4-year-old who had what was called a gum mass, so some sort of mass on their gum, and then a fussy 8-month-old. All right, we get fussy as a very common complaint for infants. So this is the 3-year-old, right? This is, I'm looking into his ear to see, this is his tympanic membrane. And just to show you what I'm looking at, I'm putting the otoscope here in the ear. And normally the ear should sort of, the tympanic membrane should be dented inward, not outward. And so, and this is where the infection is occurring. So to show you the difference, this is a normal tympanic membrane, and this one has an infection. So it's bulging out and has pus behind it. So this is definitely something that's treatable, easy to sort of discharge this patient safely. No other red flags going on with them. So this is not the gorilla in the room, okay? This patient arrives. This is the patient we were expecting. This is a real x-ray. And this was an infant that had gotten this hanger somehow through the base of his mouth down, and it came out through the skin outside of his chin. I know. Turns out this patient went to the emergency department, after he arrived to us, he went to the operating room, got it out, was totally fine. No major issues. Even though this is a very impressive image, his airway was intact. You can see the airway here on the x-ray, and it didn't hit any real major structures. So very lucky kid, but not the gorilla, not the one we're worried about, right? Here's the 4-year-old with a gum mass. You can see this 4-year-old has lost one of their front teeth. And here's the gum mass, right? I don't know what I'm looking at. Could this be an abscess? You know, what is this? It turns out this is a completely normal finding that can sometimes occur in younger patients that goes away with time. Was not related to an infection. Can be related to infection, but this one wasn't. It was just a simple cyst that resolved on its own, not the gorilla. So an unexpected patient arrives. Okay, this is one that's coming in by ambulance. It's a 10-year-old who was playing hide and seek in a building that was being constructed. I know I did that as a kid, right? Go into a house that's sort of partially built and play with my friends. And he was playing hide and seek. And I don't know if you can appreciate this here, but he got himself in this little crevice where there were these 2 boards. And that's where he was hiding. Well, there was a nail coming out of one of them, and it punctured his skull, and he was trapped. So the paramedics actually had to cut the piece of board that was around his head out and transport him this way. This is another picture of him. So they cut it out, right? We were obviously very concerned about this boy, we took some x-rays at the bedside and quickly realized that it had penetrated the outer part of the skull, but not the inner plate of the skull. And we removed it and cleaned him up, and he was totally fine. So could have been the gorilla, but wasn't the gorilla. Okay. Well, what's the only patient, that we haven't seen? Well, this fussy 3-month-old who was dropped 2 feet is the history at Core Stadium. So this was an infant that was brought in. Mother was carrying him in sort of one of those pouches in front, and per report, it kind of rolled off and hit the ground and wasn't very responsive. Baby had decreased tone, was kind of floppy, which is a very worrisome sign, was not taking really good breaths, looked pale and dusky, and really wasn't tracking well, meaning if I was to go around the infant, their eyes were not really following me well. So a lot of worrisome signals, right? Turns out this was the gorilla in the room, okay? So the patients and the infant we brought to one of our front rooms because we needed to put a breathing tube down the infant to breathe for them because they weren't breathing well on their own. And when we got some x-rays, this is after the baby has been intubated. You can see the intubation tube here. I don't know if you will be able to appreciate this. I'm going to increase the size a little bit. But what we noticed on this x-ray, and I don't know if anybody has noticed anything, but this infant had multiple, there's one here, there's one here, there's one back here, and there's a couple up here that are harder to see. There's one here. Do you see how there's a little bulging out of the bone of the rib here and here? You see that? Those are called calluses on bones. And what that means is that those bones were broken. Okay. So this is an infant that comes with just a very short fall who, after we intubate, we notice there are all these old fractures in the ribs. Okay. And that made us very suspicious for abuse. And we did a CAT scan, and this is sort of a lateral section of the head, and you can see the brain inside, and this white area is here, and you can see it all the way around here. That's blood around the brain, and that is consistent with a shaken baby syndrome. So this was a case of abuse, and this was a very critical patient. But just based on what I initially saw in all those patients, there was nothing that cued me that this was the sickest patient in the room, right? So you need to be able to quickly assess all those patients and determine what's the one that I need to prioritize. In this case, it was this infant. Even though there were a couple of more shocking presentations, like the one with the hanger and the one with the board in his head, right? This patient was actually the most critical. So then what is emergency medicine, right? Well, it's all of these things together. It's recognizing critical injury or illness. That's the number one priority, right? We have to have a broad scope of knowledge in lots of things. We have to be able to deliver a baby quickly if it doesn't have time to go to labor and delivery. We need to be able to take care of gunshot wounds, but we also need to be able to take care of sepsis or severe infections, right? So very broad, but in all of those things, we need to be able to identify who's really sick or very injured and who's okay, and prioritize patients based on that as well. Even though things are chaotic, and it feels a lot like that monkey illusion often in the emergency department, we need to learn how to kind of be calm in the setting of all this chaos going around us, right? And phones ringing and alarms going off and new patients coming in and people coming up and asking questions and patients wanting to talk to you. We also have to remember that even though we may be overloaded at times, we have to remember to be empathetic, that for many people, a visit to the emergency department is a profound moment in their life. And what they want is to be recognized for that. And for us to know they may be scared. And we need to understand what it is they're fearful of so that we can address that. And that we need to be able to rely on our skills during the time of stress. You know, I need to be able to intubate that baby, even though I may be anxious because I feel like that baby could have a cardiac arrest at any moment. I need to be able to calm myself and lean on those skills that I've been trained to do over and over again to be able to take care of the patient in that moment. I may feel it later, but in that moment, I need to be able to block everything out. So having said that, we have to be able to witness pain, emotional, physical pain, but also maintain our composure. It doesn't mean we don't show emotion or sadness, but it can't be about us, and we need to be able to do our job in those moments. And a lot of times, we don't meet people's expectations. Even though I may have to intubate that baby in the front room, the patient with the ear infection, had I not seen them first, wouldn't know that that's what I'm doing. And after an hour wait, they may be frustrated, those parents. They may be upset. They may have an appointment they had to get to, right? And I need to understand that that's their perspective. They don't know everything going on. And to be able to make those expectations realistic is helpful, but we also have to understand that they're only experiencing what they're experiencing. And we have to be able to pay attention to those details, just like in that monkey business video, right? When our minds really aren't programmed to notice it. So we have to constantly question ourselves, constantly think about what's the worst case scenario, and try not to miss that gorilla in the room. So a lot of what we do is coping with tragedy. I mean, that's a reality of emergency medicine. And I think for me personally, being able to experience it in the moment and not try and stuff my feelings down, or when it's appropriate after the patient is stable, is really important. Being able to talk to your coworkers and the people who experience some of these tragedies with you, so you can share in that the emotions you're having, is also really important in order for us to heal on a constant basis. So you might think, well, why would you do this, right? So there's so many great things about emergency medicine. And for anybody who doesn't know this book, depending on your reading level, you may find this very interesting. Maybe it's something for later, but it's a book called Drive by Daniel Pink. And what it really looks at is what makes people feel satisfied in careers. And I think it's very apropos for this talk, because hopefully, all the things you're getting exposed to are steering you towards a career rather than a job, right? A job is something you have to go to meet the bills month to month. But you really don't have the ability to sort of grow and explore the way you would in a career that you're able to build. And so the three things he found were most important for satisfaction in a career were a sense of autonomy, meaning there are decisions you can make on your own. So when I'm in the emergency department, nobody's saying you can or can't do that, Katie. I mean, if it was really outside of the scope, hopefully somebody would. But in general, I'm able to make the decisions about what's best for the patient next. You have to have the ability to develop, so learn and grow, right? I was able to do a couple of fellowships. I did an ultrasound fellowship and a pediatric fellowship. And so I was developing throughout my career. And then to be part of something bigger, right? To feel like you have meaning in what you do. It doesn't always have to be as altruistic as, helping the most people. It could be, I want to be the best company for my employees out of all the companies in this area, right? But if you really feel like you're part of a bigger picture, it creates a lot of drive and satisfaction. So for me, it's working with colleagues. It's being able to share those lived experiences that, yes, sometimes are tragic, but sometimes they're also beautiful. It's really being able to experience raw life with others in a way that reinforces humanity for me. It also has been an avenue to allow me to build. So because I worked so many years in a trauma center, and because I was involved in community work, I recognized very quickly that there was a huge experience gap between what we wanted patients to experience versus what they actually experienced. And trauma is classic for this. So, somebody comes in with a gunshot wound. What is the first thing we do? We strip them down, right? We strip them down. We look for injuries everywhere. We go through a very algorithmic approach to how we're evaluating and treating the patient that is not, it's a one size fits all, quite frankly. Airway, breathing, circulation. Then we go on to the rest of the evaluation to look for injuries in different places. And we often forget to just sort of acknowledge the patient, quite frankly, because we're so in our preset idea of how we're approaching this patient that is a gunshot wound, right? We're not thinking of the patient in the context of their entire lived experience. Is this re-traumatization in any way? Are we re-traumatizing this person in how we're treating them? And so I had the wonderful honor of being able to develop a program called AIM, At-Risk Intervention and Mentoring. And that's a program that meets youth under 30 years of age, but really the target population is pretty much 14 to 24 who are shot, stabbed, or assaulted. And we partnered with a group called GRASP, which is the Gang Rescue and Support Project, to create AIM, which allowed outside community workers to come in and be with the patient at the bedside because they have shared lived experiences, help them navigate what's happening to them so that we can just do our job and they can really be focusing on the person behind the injuries that we're treating. And then they also case manage and mentor them after they leave the hospital so that they can try and help them avoid being injured in the future. Because one thing we know is that in that age range, 40% of patients will represent with another injury within 5 years. And that 20% of them will be dead in 5 years from an injury. And so that allows us to have an opportunity to do an intervention at that first visit or even second visit sometimes to be able to prevent that ultimate outcome. And if you want to learn more about this, I'll put it in the chat, but you can go to thejavi.org. And you can learn a lot about these programs around the country. And AIM was one of the founding members of the Javi. Now there's over 40 programs. Some of them are international, and there's a lot of collaboration that's done across programs to understand best practices for how do we help victims of violence heal better? How do we do a better job from the medical side? And I wouldn't have been able to do this if I weren't an emergency physician. For the most part, these programs are started by emergency physicians or surgeons because they're the ones who are seeing these traumatized individuals, and they have the credibility to be able to go to a hospital system or go to the city and say, we need a program like this to try and stop this cycle of violence. Right, got to go to my next slide here. This is another thing I've been involved in, which is pipeline programming for high school students. And that's something that I'm still involved in. We have a program at Manual High School called Faces for the Future. And this was one of our first Denver Public Schools cohorts that we did an internship with. The program now is longitudinal, it's 2 years, and you get lots of certifications, shadowing opportunities, professionalism trainings, and a lot of bonding in the group, a lot of real deep sort of understanding of the needs of students and how to help them get to where they want to be. So that's also something I've been able to do with emergency medicine. And finally, this is something I wanted to show you because when COVID broke out, it first hit New York. I think most people remember that. And in Denver, there wasn't a lot going on. In fact, our emergency departments at that time were largely empty or near empty because people did not want to come into the emergency department because they were afraid they were going to catch this virus. To a point where when people started coming back again, I treated multiple patients that clearly had a stroke or a heart attack or something else weeks before and never went to seek care because they were too afraid. So because I was sort of twiddling my thumbs watching the news, I reached out to different organizations to see if I could help volunteer in New York and was able to connect with the government and FEMA to provide service to the Javits Center in New York City. And so, an emergency physician is one of those that is almost always needed in in mass casualty incidents or, big pandemics like this. Our skills are very translatable typically. And so this was a wonderful opportunity to be able to give back and experience, really something during a pandemic that I was able to do personally. This just shows you, for anybody who's interested and has been to New York City, we had a radius we were able to go in around the Javits Center, the area around Radio City Music Hall and Times Square on the left. I honestly, when I walked into Times Square, I didn't even recognize it because I had never seen it without people. There's a few people around here, but very, very few. And it was really surreal, but it was an eye-opening experience about the importance to me in educating the public and that informing our public about public health and why they need to be active participants. So this shows you a little. The only people I was able to see that were always out and about were the firemen, because they were also serving and helping however they could for the city. And I'm a big fireman fan, so I had to get pictures of them. This is a picture just to show you, this is when we were coming back. So we had just landed and we were waiting to disembark the airplane because I have more pictures that show even more, but there was a huge parade of firemen and paramedics who had lined up to greet us. Everybody on the plane had volunteered to help in New York. And one of the individuals who was brought back died of COVID. And he was in a coffin in our compartment and they were all meeting him to provide him with an escort. And it was really moving. And again, I felt just very blessed to be part of this experience and to be able to do a small part in what the country was experiencing. So that's why we do it. Well, sort of. But what I don't want you to miss is the unique serendipitous beauty of emergency medicine. And I have lots of these stories, but this is one of my favorite ones. So one day I was on shift and I was called over to deliver the baby that this nurse is holding. And it was a woman who was developmentally delayed, did not know she was pregnant, had taken a bus across country. And when they were in Denver, that was not her final destination, she started to develop abdominal pain. And it turns out that abdominal pain was labor. And to the point where the baby was coming out, she was saying, there's no way I can be pregnant. And this baby ended up actually being given up for adoption. And the nurse you see here, our charge nurse in the pediatric emergency department, totally healthy baby, was the next on the foster care to adopt list. She had been trying for many years and finally decided to try and adopt. And it turned out that she was next in line. And so she ended up adopting this baby. And that's Maddie. This is her a little bit older. And this is Maddie more recently. And so it's stories like that where, it just seems like there was a hand of God in it to me, that why things happened the way they did, that really gives me joy and gives me a window into some of the most incredible experiences in humanity that I could imagine. And I wouldn't trade it for anything. So that's the end of my presentation. I'm going to stop sharing and probably hand it over to the other Katie.
Yeah, right. Well, girl, I know I have a few questions, but I would love, Girl Scouts, if you have any questions or comments that you would like to share, I'd love to hear those first. So you can either unmute yourself or put it in the chat, whatever you feel most comfortable with.
And one thing I love about the Girl Scouts is that they talk about courage in their oath. And I will tell you that we often forget to say that you have to be scared to be brave. Mm. You actually, if you're not scared, there's nothing brave about it. And sometimes it's as simple as asking a question or showing your face. Shout out to Cadence. Because sometimes we just have to push ourselves a little bit to do things that are outside our comfort zone, because when we're afraid, it gives us an opportunity to be brave.
True. That is very, very true. Yeah. Edith put in the chat, it seems like a really cool job. So, well, you're talking to us about AIM really resonated with me, just thinking, because you could, you're thinking about people with gunshot wounds and things, you think, oh, we need to help them in whatever's making the gunshot wound happen and things like that.
Yeah.
And safety and first responders and things like that, and programs and blah, blah, blah. But for you to think about it in the way you could approach it and not just leave it up to those other people to solve it was just fascinating. And thank you so much for doing that. It's just like, gosh, how can I help? How can I make a difference?
Yeah.
And,
yeah. And I think, there's lots of professions that give you the opportunity to sort of think outside of the scope of what's already there. For me, if I didn't do that stuff, I think I would become more cynical. So I know there's stuff in the chat about like, how do you, it sounds stressful, or, how do you, and I think it's doing things like that help me feel part of the solution. Right? Yeah. Because if all I'm seeing is the tragedy that comes in, not to say there aren't beautiful moments like I already talked about, but if I'm just seeing things over and over again, and I don't feel like I have control over what I'm witnessing, because it's also traumatizing to people who take all of our staff, right? And if you feel that there's nothing you can do to prevent yourself from constantly experiencing that, even if I may experience it just as many times, if I feel like I'm part of the solution to prevent those things, it provides a huge psychological benefit for people. Right. And so I think that a lot of people say, oh my God, it's so great that you do that stuff. And I really think it serves me as much as it serves anyone else. Right. Because it makes me feel like I'm not just a victim, right? I'm actually, there's a purpose for me to have seen all this. Right? That's beyond the individual patient that I'm taking care of. Right.
Fantastic. So somebody has said, could you tell us more about your job? What was the most stressful moment of your career? Ooh.
The most stressful moment of my career.
I'm sure New York must have provided quite a bit of stress with your own health.
Yeah. It's really interesting. I think, part of it is your training. You're trained to do this. So taking care of people, once you get to a certain level, taking care of people is not as stressful as you would think in terms of physically doing the job, right? But I think that it's the emotional stress that often supersedes things. So when I was in New York City, for example, sure, there were medical things we had to do, but that was in my wheelhouse, right? What really I struggled with was all these patients who were completely isolated, and that they weren't able, they were in these small little makeshift, rooms that had curtains on either side. It was in the convention center that had been made into this COVID center. And the bright lights were on 24/7. Nobody could visit them. They felt very isolated. And when I would go in and talk to a patient, I worked the night shifts. That was my, I just did the night shifts because I was away from my kids and I figured, why not? And people would say, well, what time is it? And I would say, it's 11. And they would say AM or PM. They were really disoriented, really scared, not feeling well, and isolated and lonely. And seeing that many people that sort of depressed and sad was the hardest part about it. I'm used to seeing people who are ill or, and sick, but it's so much harder to be that way when it's something unknown that you don't know, long term what's going to happen. And you're all by yourself without people, really care what happens to you. And so a lot of what I felt my biggest job was to make them feel like they mattered, right? And talk to them about their lives. And there were a lot of interesting people there, So, for me, that's where most of the stress comes from now, is knowing that people are suffering, right?
Right. It's hard to not carry that too, just knowing that.
Yeah.
So one thing I also wanted to ask about is when did you know that you wanted to work in medicine, and when did you, because, I also want Girl Scouts also to know, and I think they do know, is there's so many jobs within the medical industry, so many things you could do and still be in medicine. So what was your pathway?
Yeah. So interestingly, I never thought about going into medicine. I grew up in Dallas. I was the only girl in all my science and math courses, and I was sort of made fun of, even though I was the top student. And it wasn't something that I thought, oh, I can't do that. It just wouldn't have crossed my mind because it just was not a norm. And I ended up serendipitously going to Wellesley College, which is an all women's college. The way I got there is I just wanted to be out of Texas. And I told my dad that I wanted to be out of Texas. And my dad he's considerably older dad. He's 93 now, and had grown up in Shanghai, actually. And so didn't know anything. And my mom grew up in Germany, so didn't know anything about the system. And the next day he said, come on, we're going. And he took, and you didn't argue with my dad. And we got in a car and drove to the East Coast, because that's where I said I wanted to go. And he knocked on admissions doors and tried to demand that they interview me, even though I had not applied. And Wellesley was the only place that said, okay. They had some sort of cancellation. And wow. They said, we really like her, but she's got to apply. And so I said, I ended up going there. And when I went there, because it was an all women's college, everybody had more of a voice. I wasn't getting drowned out by the men, and I wasn't, I'm very confident now, I think mostly because I just don't care. But as you get older, you're like, whatever, I am who I am. But at the time I was the girl that would blush if I was called on, like, and I don't mean just blush, I mean like deep red, like people would tell me, I've never seen somebody get that red. And I was always afraid, right, of being wrong or found out. Yeah. And you couldn't do that there. They wouldn't let you do that. And I got a lot of reinforcement for my capability in the sciences and math, and ended up working in a lab in Boston at Dana-Farber Cancer Institute. That was also very random. I just knocked on doors. We didn't have internet or FaceTime or any of this stuff then. I went there and knocked on doors, started on the first floor. By the time I got to the third floor, somebody finally said, let's give this girl a job. Ended up working there all through undergraduate and med school, actually. And I went to med school. I went to Harvard Med because my mentor in the lab was an MD, and I wanted to do research. I bench research, immunology research. And he said, if you get an MD, you'll be more favorable for grants, for grantors. They want MDs at that time. And so that's why I went to med school. Oh, and in my third year, I was doing clinical rotations. I realized, hey, I kind of like people. I like doing that.
Right.
And so ended up, going the clinical route. But it really wasn't until my fourth year of med school that I knew I wanted to be a doctor. And to me, that's also a big lesson. I mean, I think I came to it very organically. And what I found I loved about things. And I think, you may find that out right away, or you may take a much, windier route like I did. Mm-hmm. And, don't worry. go towards things you think are exciting and fun and that draw you in. Eventually, you'll hit on the right stuff. You'll hit on what you're meant to do. But don't be surprised if you don't know when you're like a junior in high school. I feel like there's such a rush now to try and know what you're going to do. And I had no clue. If you had told me this is where I would be and this is what I'd be doing at that stage, I would have laughed at you. And in fact, when I told my parents I was going to med school, they started to laugh because I was the kid that fainted at the sight of blood.
Oh, really?
Oh, yeah. I was the fainter in med school. I haven't fainted, in the last 20 years, but I used to faint at everything because I'm also an emotional person.
Right.
And I had emotional responses to things. And, one thing I always say, and I think why some women or girls don't go into medicine, they think, oh, it's too upsetting.
Mm-hmm.
Right.
Mm-hmm.
And I actually think that's an error in advice, because if we end up persuading everybody who feels deeply about the things they see and experience not to go into medicine, we end up with a lot of people that maybe don't have quite as much empathy.
Right.
And
right.
I don't know about you, but I want a doctor that has emotion and cares.
100%. Yes.
So I promise you, I am evidence that you can get through that. And I really think we need more people that often do tend to be, the female gender, that
right.
feel deeply about their patients and work through that ability to do the job, even though they feel deeply.
Right. Oh, that's fascinating and very good advice. Cora Bell has a question. What was the most interesting injury you have treated?
Interesting injury. These are very hard questions for me, I have to tell you, because
think back into that.
Yeah. I mean, not only that, but I find patients more interesting than what they present with now, right?
Interesting. That's interesting.
Yeah. I've really name it and I've seen it. I mean, I've seen patients that have had their arms ground up in a meat grinder.
Ooh,
I've seen patients that need limbs reimplanted. I've seen patients that have had a spear go all the way through their chest, but miss everything important, right? Really, I mean, I've seen patients who've tripped and fallen and have a huge splenic, spleen bleed. To me, I think at this point in my life, I don't necessarily find those interesting. I think they have definite shock value, but it really is the patient stories that I find more interesting. I'll give you one example. There's a man who came in, a homeless man from the Caribbean. He had a very thick sort of Caribbean English accent, and he was coming in for back pain. And he had been in multiple times for back pain. And the resident saw the patient and said, he's homeless. He's coming in for back pain. He always has back pain. I think he just wants pain meds, blah, blah, blah. I went to go talk to this gentleman. It ended up that he had developed very mild dementia. He had 2 PhDs. He was also a concert pianist who had traveled the world. He had grown up on an island. His whole family had taken care of a lighthouse his whole life. And his mom thought, I got to get this kid out of here and get educated. And so sent him to the mainland. And that's where he took off. And, he had spent all his money in a hotel because he couldn't figure out how to pay his bills because he had this dementia, mild dementia. But we ended up getting him placed in a facility. And I went to visit him multiple times, and he taught me a ton about classical music, right? To me, that's what's interesting now, right?
Yeah.
That's what's interesting now. I mean, I've probably seen everything you can think of. I've seen people who've tried to stuff a bunch of drugs, like mules across the border, right? And had complications of that. It's interesting. It's certainly interesting, but the stories behind the patients are so much more fascinating.
Right. And meeting all these people you never would have met.
Yeah.
Through any other way except
I went to my resident. I went to my resident and I said, do you know who that guy is? He said, yeah, he's homeless. He has that. I said, no, that's not who he is.
Right.
And when I told him, he was like, oh, wow, like I almost got none of that. And I'm like, I know, go back and talk to him. Right?
Yeah, it will enrich your day to have talked to him. Yeah.
Yes.
Cadence has asked if you has anybody come in faking an injury?
Oh yeah. People fake injury and illness not infrequently, although it's more often than not, they're seeking something else. So, we have patients who are chronically dislocate their shoulder, and they may be in jail and want to get, out in the outside world, and they can dislocate their own shoulder, to be able to come to the emergency department. We have patients who have seizures, but they're not real seizures, right? And people say they're faking it. Well, we actually don't see it that way. Almost all patients that you would say fake seizures do it unconsciously. Right. And most patients who fake seizures also have a seizure disorder. And so it's sort of their body's way of getting attention, usually for psychological angst or trauma that they have to deal with. And so, every once in a while we have somebody that really is just wanting to hang out with us for some reason, right? Yeah. Because even patients who want pain medicine, I see that as a medical condition. And I tell them, I'm concerned about your use. I don't want to give you these if it's going to harm you more. How can we help you get off of this? And we have resources for that, by the way, right? Right. So it's pretty rare. Every once in a while, we have somebody that it just seems like they want to be in the department all the time for some reason. And I can't figure out what they're trying to gain. Right. But it's pretty rare.
Right.
That's what was the funniest fake? Let me see. I mean, there was one, I would say this really was a woman that was trying to get secondary gain. And she kept telling us she was pregnant. And, all evidence pointed to the fact that she wasn't pregnant. And, I'd show her the test results, and I even did an ultrasound on her and showed her, and she kept claiming that our tests were wrong. That's different than sometimes people really think they're pregnant when they're not pregnant. Right. That can be a disorder, but in this case, it was like, okay, no, this is, she was really just trying to get extra resources. Right.
So you never know what you're going to get out of your day. She was going to be
caught.
Right.
Yeah. I have had some really sad cases of what we call Munchausen's. And that's when it's a medical disorder where people create illness, and it's attention seeking, but it's pathologic, meaning there's some subconscious, unconscious component. I remember a woman once who had injected feces under her skin and shaved her head, and said that she had breast cancer. And actually, her whole family was there, and they all thought she had breast cancer that was terminal, that had gone to her brain. And when we were able to look closer, we realized that this was all concocted.
Yeah.
But that's a much deeper sort of psychological illness than just like faking it for secondary gain.
Yeah. Wow. Well, thank you so much. Well, anybody else we got a couple more seconds, I guess. But I appreciate your time so much with us. It's just fascinating to hear what life in the ER is like, and all your stories of the good and the hard and the challenges and the triumphs, and how you can just go through that roller coaster but come out still feeling like you're making a great difference, which Girl Scouts are always behind making a positive impact on the world. You're right along with that. So yeah. Well, Sarah said that her whole family was watching and enjoyed this.
Good. My biggest advice is, do something you love. if you want to go into emergency medicine, just don't neglect yourself, and make sure you feel things in the moment, right? Don't try to be a robot, because we're not.
We're not. Great. Well, Girl Scouts, would you like to say thank you and have a good night?
Thank you so much for the presentation.
You're welcome. You're welcome.
Thank you for showing us your job.
You're welcome.
Really good.
Yeah, fascinating, fascinating. All right, Girl Scouts. Just one little last word from Girl Scouts of Colorado is with Inspiring Futures, we have a main patch, which if you've attended one of these before, then I've already mailed one off to you. But if you haven't, I'll be sending out an email so that you can complete it all and fill in your address, and I can send that patch off to you, and it'll be something you put on the back of your vest or your sash. And this is a little bit of STEM and life skills, because Katie, we have 4 pillars in Girl Scouts, which is entrepreneurship, outdoors, life skills, and STEM. And so in our Inspiring Futures, we cover professions that kind of range in all those, but I think we have a bit of everything in medicine. So entrepreneurship with the aim and everything. So yeah, awesome. So Girl Scouts, you'll be able to get that patch, and maybe we'll see you at another Inspiring Futures in the future. So thank you so much. Have a great night, everybody.
Bye-bye.
Bye.
Bye.